What's up, guys? Welcome to the Couple Nurses Podcast with your host, Matt Sartrick, and myself, Peter Fundura. This is a podcast where we tackle current health news and hot nursing topics, one conversation at a time. Thank you guys for tuning in on this beautiful Friday. Hope you guys check us out on Patreon. That's right, Patreon is out. It's live. Got some good stuff on there for you. Thank you for everybody on YouTube. Make sure you guys leave a comment. Make sure you guys subscribe. Hit the notification bell. Vlogs coming out weekly. Couple of news coming out weekly. We got some interviews coming up throughout this whole month and probably the next month. And guys, don't forget to rate us. We like those stars. What's up, Matt?
I'm doing fabulous, man. Guest number 2 of 2021. Welcome. We would like to introduce our returning guest, Kamil Sledz. And Kamil is an OR nurse. He is also a nurse practitioner student and has a YouTube channel called Kamil RN. And he also had COVID, so why not chat about that, right? So we're gonna discuss healthcare, nursing, COVID, what it's like during this pandemic. And if you're interested in him, you could find him at Kamil RN _. How are we doing, Kamil?
I'm doing pretty well. I'm happy to be on the podcast again. This is very exciting. I've been looking forward to it for the past few days. Like after I got COVID, I was at home. I was quarantined, just scrolling through my phone, and I would always see you guys, posting stuff, like talking about nursing and healthcare and COVID. And I was like, you know what? I got an idea. I want to reach out to Peter and Matt and ask them if, they would be interested in talking to me about having COVID, because I had some pretty unique symptoms, I think. And like with my whoop strap, I had some pretty cool things that happened. So I thought, why not see if they would want to talk to me? And here we are.
So let's tackle the elephant in the room. How did you feel during COVID? How did it feel like? What did you, what happened then?
So it all started out like New Year's Eve. I was on my way to my sister's house. And in the car, on my way there, I got a notification on my phone. I opened it, and I opened my Whoop app, and it said that I'm in the middle of an activity right now, and I'm at 11.8 strain. I was like, what the hell? Like,
No way.
I'm in the car. What's going on? And I checked my heart rate. It was like in the hundreds. I was like, what's going on here? And I was like, maybe I had too much coffee or whatnot, And then I got to my sister's house, and I started to get like very mild diarrhea. And I thought, you know what? I had some beers. Maybe it was beer shits. I was like, whatever, let's keep on going, And then a few days later, like I started to develop some congestion. I never had a fever. And then on the Monday morning after New Year's, I woke up. I felt like I got hit by a truck. I was like, I feel like crap. So I woke up. I was like, I don't have a fever, so I want to go to work. I went to work. I was a early start for a ortho case. I did the whole case, but I felt like crap the whole time. Like even my coworkers were like, "Are you feeling okay?" Because I was like, I felt hot, but I didn't have a fever, and I was just like mentally not there. I just felt like crap. So I asked if I could go home, and I went home in the morning, and I went straight to get swabbed for COVID, and it came back positive. And I was like, well, that explains that, So I then went home, and for the next few days, I was in bed like with a crazy headache and extremely dizzy and fatigued. But I never had a fever, never had a cough. I just had a bit of congestion, and yeah, that's about it. It was pretty crazy. Also, like the few days leading up to New Year's, and I noticed my Whoop app, my strain was high. Like my recovery was consistently low. I was like, what's going on? Like I'm getting enough sleep. I'm doing all the things that the Whoop app like recommends. Don't eat, close to bedtime. Don't drink alcohol close to bedtime. And I was doing all these things. I was like, what's going on? Like, is this like Whoop strap not working? And then I got the diagnosis. I was like, oh, that explains it, So yeah.
Yeah, it's probably HRV that the app kind of picked up most on, right? Like
Yeah.
the Whoop app. So as soon as your HRV is low, like, is it stress that you're experiencing, physically, or from working out or having heart shifts and all that, or is it from a mental standpoint, or it could be just sickness, and that's probably how everything got triggered.
Yeah, it's cool. I want like I wish the swoop strap had more. Well, because if you think about it, the Whoop strap does have a lot of variables that they play around with, like respiratory rate, and it tracks your whole activity. So Whoop strap actually did a good job because this is continuous monitoring, right? So they have so much variables to incorporate that they could figure it out pretty well. Like even with the whole recoveries, like the recoveries are probably more accurate now than they have been a few months ago. Because I think I'm like my 6th month of wearing Whoop now. So imagine how much data they have compiled on me already, and imagine how the AI program, if they do have they're doing it properly, it should adapt to me, right? So as you prolong the Whoop wearing process, the more it's gonna know about you, and it's gonna be able to better predict everything. Because now, what I notice is what's happening now more frequent than it did before is it's actually logging my naps without me actually putting it in. So my work naps actually are getting tracked these last couple of shifts.
Wow,
which is interesting to see.
I don't have that.
And even when I napped before my last shift, it tracked it. So I think over time, I think it's gonna get to know you a little bit better, and it's gonna automatically track certain things better. Yeah. The only thing is still is with activity, me lifting weights, it doesn't raise my heart rate very much.
Yeah.
So it still doesn't track it automatically. So I still manually input it. But if I like Stairmaster, if I do cardio, it notifies it right away that I'm doing an activity.
So you mentioned something there. You said work nap.
Yeah.
What's a work nap? Like I don't heard
It's
that
a Cali
in
thing.
California. Yeah,
It's definitely a California thing.
That's nuts.
Yeah, so we have breaks where the nurse completely takes over our patient for us. So we could leave for that amount of time.
Oh, jeez.
So what we do is we decide to take a nap, You get like a blanket
Nice.
or like a hoodie, and then you cozy up for a half an hour or however much time you have. And
What sucks?
that's it.
Yeah, what sucks now? You mentioned naps, right? We used to have a whole room dedicated to naps. There was literally a whole circle of recliners face to the wall, and you could be like 10 nurses at once, all just like knock the hell out, or
That's
like
awesome.
And like now though, you can't do that because of the whole distancing, and they're thinking it's a threat for spreading infection, so they lock that room down. So now it's harder to nap, and you gotta like find specific. You just gotta go on a flat couch sometimes, or like some patient waiting room type of facility at night, and just like crash really quick.
Yeah, but it's nice, dude. Definitely works, man. Naps are I love it. And I always have my break right before I have to draw labs. So my ideal break time is between 2 a.m. and 3 a.m. I do 1 a.m. too, because then I come back from my nap and I go straight to drawing labs and straight business. I have a whole routine figured out.
Yeah, if your day runs like that.
Yeah.
Kamil, I was wondering, like, how is the OR during the pandemic? I know like elective procedures were stopped at one point, then resumed. I think we had a phase where it opened up and then it closed up again. I don't know what's going to happen now because of the cases going down. How's your experience?
Yeah. So in the height of COVID, like in March, April, May of 2020. Like the operating rooms were like completely closed, at least in my hospital, and to my understanding in hospitals around the nation. And it was like a ghost town. We only operated if it was like class A emergency. So like a ruptured aorta, for example, like that's a emergency that we will operate no matter what. But it was like, it was for the first few weeks, management didn't really know what to do with all the OR nurses, because we would basically get to work, sit there for 12 hours and do almost nothing. Say if all like the organizational stuff and housekeeping stuff was all complete, then either we would work on like our health stream, which is like the continuing education, or just hang out and wait for a hopeful surgery to come along. And after a few weeks of that, management was like, let's use the OR nurses to help out on the floors where they're needed, because our hospital was getting slammed by COVID. So there was a few nurses that went into the ICU who had ICU experience. There was a few nurses that helped with housekeeping. There was a few OR nurses that helped up on the med surg floors. And I was one of the few nurses that went up on the med surg floors. So that's what they did. And we would hold off elective surgeries until we had at least 20% open beds, for all the post-operative patients to occupy. If we did not have that, because these beds would be filled with COVID patients, then we would not do elective surgeries. And that's how it was also the second time around too, in the spike at, the end of summer too. That's how it was.
Yeah, it's crazy.
Yeah.
We have a few clean beds. What's like 4 or 5, I want to say, in the ICU, something like that, maybe 6.
That we maintain.
Yeah.
Oh, that are open, yeah. And everything else is like COVID.
Yeah.
Yeah.
Everything else is literally COVID. Yeah. So how did it feel going back to bedside? Because you haven't done it for a while, right?
Oh yeah. I was not looking forward to it. Like, I have nothing against bedside nurses. It takes a very, I feel like it's just not for me doing bedside. When I was up there, they had me like reorientate for bedside nursing, and I haven't done bedside nursing for like 2 years, so I haven't started an IV. That means in 2 years.
Damn.
So I was like, all right, let's do this, and luckily they set me up to the floor I was on before I went into the OR. So I knew more or less all the nurses there. But no, like, it was fine. Like, at first I was stressed out about it, because I was like, yo, I'm putting my license at risk, because I haven't worked bedside and I could screw something up. Like, the medications that we use in surgery are completely different than the ones we administer up on the floor. So I'm like, I even, had to like, I had to refresh my memory on like certain like antihypertensives and antibiotics and all this stuff, because it's just not things we use in the OR. Yeah. And I was up on the floor for about a month and a few days.
It's funny that you mentioned the whole starting IVs, because we have the same experience almost. Like, everybody that's in ICU right now is intubated. So they usually either have an A line or they have a central line. Like we are not starting peripheral IVs at all, man.
Rarely,
Like,
yeah.
and I don't do any butterfly sticks to draw my labs because usually everybody has access, man.
Yeah,
Like it's totally different. The ICU is like, yeah, even just gowning up and like making it seem like it's out of a movie and everything else, like it's a trip.
It's been a while since I started. It has. It's probably been like, I want to say, at least, maybe like 5 since the beginning of the contract. Probably. I think I started 1 IV so far in a hospital, because everyone's like, it's a central line. Everyone's got trialysis or triple lumen. That's crazy, dude.
Yeah, even blood sugars, for example. Like we have A lines on most patients. I don't even have to do a finger stick to get blood. I just like pull back on the A line, and I take an insulin syringe, pull back, and we have runners in the ICU to help out. So there's already somebody standing outside of the room with a glucometer. I pour the blood on the little alcohol pad. I give it to her. She scans it, and then after she shows me the blood sugar, I pull it away in the room, the little strip, so it's all sterile. Nothing's getting contaminated. And then whatever the blood sugar is, she could scan my medication through the glass window, so there's no contamination. And I pull up the amount of insulin. We could do the verification. Hey, this is how many units, and business is done like that.
Yeah, it's like so much more standardized now. Like nursing,
there's a standard practice.
There's a protocol for everything. There's a whole like before. When this first started, it was you had to have a PAPR or a 95 to enter the room and a gown up and everything like that. And then it's like progressed with that. Yeah. Now it's like you're trying to cluster care, trying to be in the room for like maybe 4 or 5 times a shift instead of walking in and out nonstop. Like everything is standardized. Yeah. Like labs, we put, usually we tape baggies to the outside of the door, we draw the labs, and then we drop that lab into that clean baggie outside the door. And somebody picks them up and then drops it off, at the tube station.
Or you do it yourself.
Yeah, or you can do it yourself when you've gone out or gone off, dude.
And it's interesting to think about, even after COVID, how many of these things are going to continue and like become just like how things are done. Mm-hmm. I remember like a few months ago, we had a meeting with the director of nursing at our hospital, and she was like talking about the kind of stuff what you just said, how like things now are going to be different for a long time, if not forever, and she mentioned that she asked all the nurses who worked during the AIDS epidemic, and a few of the OR nurses, the older ones, they raised their hands, and she asked like, what's one change that happened after the AIDS epidemic? And I was like, I don't know, but these older nurses said after the AIDS epidemic, it became standard practice to wear gloves and switch out gloves between every patient. I was like, wait, what?
No
way.
Like,
yeah. After the AIDS epidemic, gloves became a thing, it became standard practice. And then she said, like, now masks are going to become a standard practice, at least in hospitals, for all healthcare workers. When you go into a hospital, you put a mask on, that's just what you do.
That's mind blowing.
Yeah, that's a very good perspective. One thing I worry about though is I hope that masks still become a standard practice for our society, that everybody has to wear. Like
outside a hospital.
I don't think that should be the norm, because if anything, I think that's scaring people more than anything. Just interacting with California residents, it's like everybody seems sick to you. Everybody seems like they have the virus. Everybody should stay away from me. Yeah. Like that's like the vibe that I'm getting, and it's weird because masks weren't meant to be put on healthy people. Like this is the reason why I freaking eat healthy, work out, and do everything else. So I could be fit and interact with society and have a strong enough immune system for that.
Exactly.
Yeah. Look how much they've already incorporated masks into our society. Like imagine yourself in like 2019. Imagine if you saw somebody wearing a mask outside.
Yeah.
Like,
like,
what the hell? Like, yo, that guy's wearing a
Frowned
mask.
upon.
Like,
Yeah.
dude, yeah, you'd be like, why is he wearing a mask? Probably got some crazy disease. Now it's just like
probably
a
has
normal
cancer,
thing.
immunocompromised.
Yeah.
Like, you don't know.
Yeah, now it's just like, oh, it's just that you don't even think about it. It's already just how you've already been slowly programmed to view people.
Yeah.
And like I said, hopefully it doesn't happen in like outside the hospital kind of stuff because we don't need them technically outside the hospital. You know what I'm saying?
Yeah, like I'm not a immunologist, but like, yo, we have an immune system for a reason, you know? Like you don't have to be walking around like sheltering yourself from every single, from everybody else with the fear that you're going to get sick. I mean, you've lived your life up until now being exposed to God knows what, and we're still alive thanks to our immune system,
Yeah, people are gonna die regardless. Like if it's not COVID-19 taking people off, it's sharks in the ocean, falls, whatever, strokes, diabetes, cancer. Like there's always gonna be something to die from, right?
Yeah.
So like it's almost trying to prevent the inevitable now at this point. But now I feel like we're not even trying to prevent the inevitable. We're just trying to like instill these values and these mindsets in individuals regarding like immunology, regarding virology and medicine, saying that, hey, don't think for yourself, don't do your research, just, hey, trust us, we know what to do in this situation, right? And it's been politicized. Like think about it, guys. New president, right? How is there a new president and now there's already been a week or almost a month of COVID decline? Like what happened? Did this switch in presidency cause COVID-19 to stop being as effective as it was? Or what's going on? And California said that they're going to start releasing numbers.
Yeah.
Like, how does that make any sense?
Yeah.
Like, it doesn't make no sense. It's like
sense.
corporate America back at it, dude.
Right. And that's what yeah. Also, like, we need to realize how important this immune system is, where we need to be exposed to other, like, people, because that actually helps our immune system stay, like, sharp, It's like working out. If you only worked out once a month and you had these maxes, right, you could deadlift 315. You can't just deadlift 315 next month. Like, your muscles need to be constantly, like, well lubricated, like a fine-tuned machine. And that's our immune system. So by us, killing bacteria on every single damn surface and constant hand hygiene and masks, like what are we exposed to? Just our own flora. Right. What are the long-term consequences of that? We don't know.
Yeah,
we're going to see it.
And this whole vaccine too, with the whole booster shot, like you need 2 vaccines to fight out this one virus, and then are you gonna need another one for the next strain? Like, is it gonna be a continuous effort? They've been thinking about combining the flu and COVID shot together to make it just one shot.
Yeah, like, and that's what's weird. It's like we're not talking about being healthy and being like self-sufficient. The news is like, oh hey, you need this, and then there's a new strain, we need a booster, and now we're just being consumers again, and just a different product that they have created, which is vaccines. That's what like food is, processed foods, all this crap. It's weird, man.
Instead of like instilling that mindset in, I could buy by protection, like with vaccine and stuff, we're not talking about how to prevent your body from getting destroyed by it on its own, right? Like CDC just put a vitamin D on there, like what, last month?
Yeah.
Right? Like what? Like this was known months and months ago. Nobody wanted to address it.
Yeah.
Because it's a cheap and effective way to do it, and no one's gonna be able to make money off it, right? Compared to a vaccine.
Yeah, like it kind of speaks for the culture, maybe, like there's always that easy way out, like as opposed to staying healthy, eating right, working out, like there's always that easy way out. Like I'm not saying that everybody that gets the vaccine is looking for the easy way out, but I've met a handful of people who are like overweight, they have diabetes, hypertension, and they have the audacity to preach, like I'm getting the vaccine to prevent myself from dying, from getting hospitalized, and I don't know, it just seems like you have other issues you should address first, or as well as on top of COVID-19, get your hypertension in check, get your diabetes in order, start eating healthy, lose some weight, and that'll that'll get you very far in not being as affected by COVID-19.
Yeah, both my grandparents had COVID-19, and they have diabetes and they have hypertension, but that's just because they're older in their 70s. So
Yeah.
that kind of comes with age. And they both survived it fine. Like, yeah, they said they were very sick. They felt horrible, but they came out of it fine. Why? Because they're not super unhealthy individuals. Just the diabetes that they have isn't because of their consistent bad eating. It's just because they're older and their pancreas is able to produce enough insulin as much as it did before when they were younger. That's what it is. So that's it's not really as strong of a comorbidity as somebody that's like 60 years old and that just eats junk food, McDonald's all day, and they need that insulin, and they're diabetic because of the stuff that they eat. Their pancreas produces enough. It just does. Their pancreas produces insulin at a good rate, but the amount of carbs and sugar they're consuming the pancreas isn't able to catch up. So that support with that insulin.
You guys paint a very good picture, because my grandpa is he's 74, 75, and he has COPD, very bad. He was a carpenter for a long time, breathing in all those wood chips. Like he gets winded when it's winter. He can't walk. So he got COVID and he did just great. He lost his appetite to eat, a little fever. They do little Polish remedies, but he was fine. So it just shows you that COVID could be less of a respiratory issue. It's more of a metabolic issue that we're facing, and this is what's leading to actual death. And that's what we see in the ICU, dude. We see patients that are undiagnosed diabetics coming in with HbA1cs above 6, even 7s. And this is the reason why they're intubated on ECMO and they're on insulin drips, and we're fighting more of metabolic problems.
I think as we move on in medicine, we're going to be able to separate, say, for example, hypertension and diabetes, because they're pretty easy examples to kind of explain for this idea. I think as we move on with medicine, we're going to be able to differentiate between hypertension caused by someone's lack of exercise and nutrition versus hypertension caused by somebody that just genetically predisposed to it. And I think they're going to be able to separate these things on such a good level that they're going to be able to kind of treat them differently. Like hypertension due to genetics, is it going to be not as big of a predisposition to dying from COVID-19 as hypertension due to poor diet and poor exercise? You know what I'm saying? I think that's how deep medicine is going to go. And even with diabetes, you're going to be able to differentiate diabetes between diabetes you got from the food that you eat, or diabetes that you got just from being old and just because your pancreas is just kind of slowing down in time. If we already haven't, but I feel like that's gonna be more mainstream.
Yeah.
It's gonna be instead of type 2, type 1 diabetes, it's gonna be diabetes due to diet and exercise. It's gonna be diabetes due to age. That's how deep we're gonna be in the sauce.
Even Alzheimer's, we know that Alzheimer's is insulin resistance in the brain technically, and it's called type 3 diabetes. Why hasn't that been discussed? We're still treating it as neurodegenerative disease. What if it could be a different predisposition?
Right. Isn't that crazy?
And ultimately that has to do with medicine, but it's also physicians. They're so overworked that they don't have the time to do research and think of and brainstorm new ideas. Just like nursing has become tasky, physicians have a very task handy too, where they're just going down the row and ordering these things. This is what's going on. This is the standard, not questioning the norm, not saying, hey, maybe we should look into different things.
Mm-hmm. Yeah, but then you have the medical side of it where you have professors, they get together and they have these sessions, but I'm not sure what goes down in those, but I'm sure a lot of crazy ideas pop up.
Yeah.
But yeah, definitely overwork. If you're overworked, it definitely shuts off that whole creative intuition and creative mindset in your head. You just have time for it.
Yeah. And that results in T population not being as educated, which affects their health,
Yeah, I think that's a huge correlation as well. Mm-hmm. I was going to ask, how is the nurse practitionerships going? How's school going with everything?
Oh, yeah.
And online classes, that must be a headache.
Yeah,
I'm gonna go to
it
you for
is a headache.
my yearly physicals.
Please. That's gonna be
And
in a
my
few
prostate
years.
exam
So
too.
I got the lube ready, dude. So no, it's good. The program I'm in is 3 years long, so it's kind of made for like the full-time working nurse, where for the first 2 years of the program, it's all online. So we haven't been really affected by the quarantine because it's all been online. Anyways, I still haven't been on campus at the university I'm at because um, I started in the beginning of 2020, and we were supposed to have like a orientation, but that I canceled. So I'm already a year and a few weeks into it, and I still haven't been on campus, which is pretty crazy. But then after these 2 years, we have a whole year and a semester of clinicals. So it's pretty exciting. At the moment, it's pretty manageable. I'm just doing one class at a time. So I work full time, and then this program is considered full time. It's specifically it's the family nurse practitioner track, and it's a MSN. Yeah.
Do you know what kind of NP you want to go into, like acute or family?
Yeah. So um, I remember when I first started to consider the nurse practitioner track. I never really thought like, hey, I'm going to become a nurse practitioner until I actually started working in the operating room. I met these cool nurse practitioners in surgery. I was like, wait, what? I didn't know that NPs could work in the operating room. I was like, I've heard of physician's assistants, being, specializing in surgery, but I've never heard of NPs. So these guys, what they are, they just had OR nursing experience, and then they got their RNFAs, which is registered nurse first assist. It's like a certificate that you can basically perform surgery under the direct supervision of a surgeon. So you can like close incisions, you can even make incisions, and you're basically operating then, and it's also like a slight increase in pay. And then these guys went back to get their nurse practitioner, and that provided them with, the ability to be healthcare providers and assess, diagnose, and treat patients, as well as assist in the operating room. So what I want to do is kind of like that, where be a nurse practitioner that works alongside a surgeon that I can help him out or her out by having office hours, seeing patients in clinic, doing consults, doing pre and post-op rounding, as well as helping out in the operating room. And the advantage of being also a nurse practitioner and having this role is that as a healthcare provider, then you can bill to patients' insurance too. Mm-hmm. So that provides a slight increase in pay as well. So that's kind of what I want to do. I've already had a few surgeons I work with like ask like, hey, how long do you have left in school? Because I'm looking to hire a nurse practitioner. And I'm like, hell yeah, dude. I've got a few years left. So yeah, this route I want to take is kind of a non-traditional route. It's more like unique, but it still exists. And not many people know that you can be a nurse practitioner and also like help out in the operating rooms.
And it's
Yeah.
cool because when we're in a pack here, I was looking at their schedule, what kind of surgeries are performed, and there was a orthopedic surgeon that had cases that were literally overlapping. So he was from like 8 to 10, but at 9:45, there's already another case that's going to be started, or 30 minutes prior, and literally he has I think PA, I don't know what they use here, that like assists him. And as he's, going to the next room, starting the procedure, she's finishing up the patient, whether it's probably suturing or whatever procedure orthopedic surgeons do, closing him up. And this guy is technically making more money in the long run, and he's helping the hospital profit because he could do 8 surgeries instead of like 6 or 5, a day. Like, it's pretty cool.
Yeah,
when I did insane.
When I did my like OR like shadow rotation, we literally had so it was at my old hospital. It was a heart transplant, which was very cool to see. And we had a team open up the chest. Surgeon came in, did the cuts or whatever. No, we actually had somebody come in and start the person on a bypass. Then somebody else opened him up. Then a surgeon came in, did his part, left. Different team closed them up, and the surgeon just kept going from room for room, dude. Yeah. And he would like some of the rooms, like a surgeon would be doing the OR, like the surgery on the heart, and he'd just hop in and help him out real quick. Like, just check it out. Like, he just have a few tools. Like, the one surgeon's operating on the patient, another surgeon in there, like, doing his own thing, like, just looking through shit, and he leaves. Like, it was interesting to see. Yeah. And they have, like, a little conversation, like, hey, like, how's your day? They have the rock and roll music playing in the background. Like, it's very, it's some shit goes down, dude. It's very, like, focused on, like, one thing, what's going on, right?
Anesthesiologists do it the same way. And that's why CRNA is becoming a thing as well, is because a hospital can save money. Why have 4 anesthesiologists doing a surgery where you have 3 CRNAs, right? And then the anesthesiologist just has to come in from the beginning, watch how the patient is being sedated, and he goes over and checks in the other OR while the CRNA is managing this patient. And if they have critical questions, they just could hit up the anesthesiologist right away. He's right there because he's, and that's when I shadowed CRNA. That's what I seen. I'm like, wow, that's freaking cool. That's efficiency,
Yeah, and that's exactly what I see as well. Like the CRNAs are in all the rooms, and the anesthesiologist is there to help them out, give them lunch breaks. Just make sure that there's that everything is going well, and also like with the ortho surgeons, we get this one ortho surgeon once a month. He has a PA and his own RNFA. He's so efficient. He does like 8 or sometimes 9 hips or knees, like orthoplasties, and these are like complicated surgeries. But how it works is that he hops in a room, he opens up the knee, puts the implant in, and then once the implant is cemented in, he leaves, his PA closes, he hops in the next room with a whole other team with his RNFA. They start, that patient leaves, then the PA hops in and helps them out, and then it just goes on and on and on. And they can be so efficient. It's insane. Damn. That they can have 8 like total knees done before like 3 p.m. I'm just like, this is insane. Yeah.
That's why it's super efficient. I wonder if bedside nursing could become like that, where, and it's already happening, how there's like IV start teams and all that. Imagine having teams for specific sections. But like, again, what's the issue? Cost, right? Like there used to be lift teams where they come in and use lift patients for nurses. Why did that disappear? Budget.
Imagine if there was like a bathing and turning nursing team, like a group of 3 nurses that just bathe everybody, turn them. That's it, room to room to room to room.
You have no idea what kind of decrease of workload that would be for us if I don't have to do 2
Also,
baths on
like-
both my intubated patients.
Yeah. Also, like hygiene in patients would increase probably significantly because, I mean, Peter, like you worked in the nursing home with me. Can you imagine if we had just like nurses whose only job was to just keep the patient clean? Like that's all they did. Like, how would that affect like infection rates and mortality? You know, like that's like the basics of nursing. Even Florence Nightingale was like, keep yourself clean, you know, it'll reduce infections significantly, it'll increase your lifespan. Like, have we forgotten about that? You know, like, yeah.
Like,
The top things that people die from the hospital isn't it pneumonia and sepsis, which is basically 2 infections, you know, one of the lungs, one of the blood.
yeah, do you ever wonder like what's the correlation there? We don't know, you know. Like, of course, I do my best job to keep everything, you know, aseptic and stuff. But hygienists, with everything that's happening in the hospital, how busy it is, we're hanging pressers. Like, hygiene is probably most neglected because
Definitely.
because you could miss your patient's turn for that hour or whatever you missed, right? But you can't like not forget to draw labs. What's the PTT? Adjusting the heparin. Something's happening with the other patient. He's desatting. Those are those issues. Hygiene is neglected, man.
Right. Yeah, that's so true, dude. I think we'd see a lot less like CAUTIs, CLABSIs, even maybe sepsis if they could implement like these teams of nurses that would just bathe up a patient and clean them. Because sometimes you do a bath, you chart they did the bath, and you kind of just wiped it down real quick just because you're so busy.
Yeah.
And you know, I wanted to say like I've done it myself, but that's not the most hygienic thing to do. Like I make sure to always scrub the central line, but the rest of the body, like it's not the most important thing at that point in time.
You're saying it how it is. And what if we need people to speak up about stuff like this?
Yeah, it's like the unfortunate truth, you know. That's just how it is. And you know what? I have to say, like, that was a part of the reason I just wanted to leave bedside nursing. I was like, is this like what nursing is? Like, I just felt like I just envisioned it differently in my mind because you're so overwhelmed. I was just going in and out of rooms, making sure I hang my meds on time, making sure that I answer all the call lights and I chart and I call all the doctors and report all the labs. You know, I was like, what about just like the basics of nursing? Like, this is not like what I wanted to really do. And I was attracted into the operating room because it was clean, it was structured, you know, you knew what your role was and you did that, as opposed to a bedside nurse. Not only are you I think overworked with all these patients and doctors and medications, but yeah, I just think that the operating room provided you with that structure, and it gave me like a reason to, let's keep everything here clean, because it's been proven if we don't, the patient will get a surgical site infection, and that's just standard practice, and there are no shortcuts. The amount of times I've seen nurses take shortcuts, like chart, I gave a bath, but they didn't. They just, half-assed the bath, and that's just kind of like disheartening. I was like, I can't continue to work in this kind of environment, and I opted out to leave. But I think the real respectful thing is, or like the solution is to like, how do we address that? Yeah.
That's a good point, man. Like, it's a good thing you bring up. Like, unfortunately, that's how sometimes nursing is, and you can't really like do anything about it. And if you like organization and going by the standards and everything, then OR definitely for you, because especially like med surg and tele floors, you're never on your own schedule, right?
No.
Like you have an idea of what you're gonna do when, but then hey, you got these two call-outs that popped up, you took care of both of them, now you're an hour behind. You never work on your schedule, almost like you're working on a patient schedule.
Yeah.
That's why like we prefer or at least I for myself, I'm sure you could agree with this, is why we prefer the ICU, is because majority of patients are intubated, sedated, and if they're intubated, sedated, for the most part, they're on our schedule.
Yeah.
But of course, things happen, blood pressures tank, people crash, we adapt. We adapt, adjust, and overcome, basically. But for the most part, we always have some kind of a structured schedule for ourselves, because we know when we're going to give them the meds because they have an NG or they have a PEG, right?
Yeah.
We know when we're going to do their bath because they can't say no. Or a patient's not going to hit the call light wanting something at that time because they can't, right? So that's why we have a lot more control over the patient than other floors. Like in the OR, you have complete control over the patient because you're opening the patient up. They're always sedated. They're always intubated. They're always not able to do anything.
Yeah, but like if you devil's advocate here, I think in med surg you have control but in different aspects. You have control in, hey, your patient's blood pressure is not going to tank. There's more stability there.
Yeah.
So her uncontrol is the call light compared to your patient is tanking, or you got a mucus plug in there desetting and now you're running in there. So it's a different type of control too.
Yeah, and completely agree. And I like the control that allows me to titrate the medication to fix that pressure instead of me bringing in more juice and crackers because you were hungry at that time.
Or I got a tummy ache and we have to do something about this.
Yeah, both
it's a different type of issue.
Yeah.
Both unpredictable, both things you got to handle, but I just prefer to the one that leans more towards the critical blood pressure compared to the applesauce and the cranberry juice.
But like what you guys are explaining, it kind of sounds more stressful. Like, would you think that med-surg nursing was more stressful, or ICU nursing?
No, definitely ICU nursing. More
Clearly, bringing cranberry and apple juice is more stressful for us, as you can tell. But no, I'm not gonna lie. Like, there's days.
Actually, think about it. That frustrates me more than a patient's pressure. And like that kind of situation where call lights and needy patients. Like, I understand you're in a hospital, you're very sick, and we want to help you best we can. But sometimes, like, we're real busy, and we can't always give you the type of hospitality that you want, right?
Yeah.
So that does stress me out, and that frustrates me more than the taking blood pressure.
Yeah, but you know what? Like, I miss that nursing. Where I had a relationship with my patient. I talked to them. I asked them questions. I knew about their hardships, what's going on in their head, what's stressing them aside from their health. Like, I was able to help, and like, I feel like I could be a freaking awesome lifestyle coach if I wanted. Like, I could coach people, right? It was cool helping and doing that on that end, aside from just taking care of them from like the physical body standpoint, and that's lost now because everybody has a breathing tube in.
But now you still get the other parts of the ICU where you get that patient that's ready to transfer, and you could have a genuine conversation. And usually, like, when a person almost died and he's getting better, like, that person is really emotional, and it's almost like one of the best times to talk to a person because they tend to reflect on stuff. So you could always ask for guidance, and you could also implement ideas, because what they're going to be focused on is how is their life going to be different now than it was prior to coming in the hospital.
Yeah.
So it's a good time for them to reflect. Like you said, you get a lot of knowledge from them, a lot of perspective, and it's also the best time to teach because now the patient is stepping into a life of the unknown, basically. Because, hey, they just had a cavity, they had a heart attack, they were unconscious for a week. Now they just woke up.
Yeah.
And doctor says, hey, you had emergent double bypass, you got to complete change your diet, we got to start exercising, we're on these meds. And the patient's like, holy shit, I wasn't no meds coming in and I didn't exercise, nor did I care about my diet. And now I got to change all this. So it's a good way for them to reflect on how they messed up their lives, which is where you could come in, have a good conversation with them. Hey, how was your life before? You ask them for intuition and stuff like that. And then you could also guide them. Yeah. So they could guide you through life, not to make the same mistakes that they've made. And you could guide them through their new life based on mistakes that they've made that you haven't made.
Yeah, that's cool.
And you can actually see that firsthand. And, I'm sure it also affects your life and your health too. You're like, all right, not going to make these mistakes this patient did. I'm going to stay on top of my diet, my exercise, Yeah.
Gentlemen, it's been a pleasure talking to you. Kamil, we appreciated you being on. Sorry for the background noise. I'm noticing they're freaking cutting the lawn right next to us, super close.
That's all right.
And if you want to know more about Kamil or his YouTube channel, visit him at Kamil RN, correct? And on Instagram, Kamil RN _.
Yes, that's right. Thanks for having me, guys. This is awesome. I hope to be on again sometime in the future.
Thank you so much, man. We love having you on. Let's push for Kamil Sledz number 3.
Let's do it.
Trilogy. Peace, brother.
Bye-bye.
Peace. Yeah.